Hey, everybody. I just wanted to record this lecture on lung transplant imaging and postoperative chest. The goal is really to make you aware of thoracic surgical language, to improve your reports, discuss what's important to include in your reports, and to show some common surgical appearances and complications. I'm going to talk about the surgical options for lung cancer and briefly about lung transplant and subsequent complications. Also run through some common cardiothoracic surgeries, just so you are aware. As far as general surgical options in the chest, you have a lobectomy. They're all pretty self-explanatory, but just to be familiar with the nomenclature, pneumonectomy is removal of the entire lung, wedge resection when you just take a little wedge out, and then segmentectomy, segment. And the decision on which one of those is appropriate is a combination of size of the mass or nodule, location, and functional reserve of the patient. It's a typical postoperative lobectomy. Just by looking at it, it's not always easy to tell whether it's the what lobe was taken, but you can see elevation of the left hemidiaphragm that will remain there chronically. Sometimes it'll even look like they have a small left effusion, but that's just the diaphragm being pulled up. So always good long term to, instead of calling that a small effusion, just check and see if they have a chest CT or an abdominal CT to see if there is an effusion there or if it's just a normal postoperative appearance. Then you're going to have midline shift to that side as well. Here's a case, 85-year-old smoker who, this was read as a right upper lobe mass, FDG avid. They went to surgery. They had a right upper lobectomy on their first CT scan after surgery. This is actually the middle lobe. So if you do a right upper lobectomy, the middle lobe swings up. So this is tumor recurrence, what was thought to be tumor recurrence in the middle lobe. But if you go back to the initial study here on the sagittal, you see the mass in the upper lobe and you see it's invaded the middle lobe here. So it is important. And you can see that same mass on the post-surgery follow-up. It is important to be correct about which lobe it is in and if it invades into another lobe. This is a common postoperative appearance of pneumonectomy. Again, volume loss. The hemithorax fills up with fluid. That's normal. As you watch, this is a case from online. It's a common test question. If you see the air fluid level in a pneumonectomy cavity drop a couple days out, that's a bad sign. We want it to be filling up consistently and the air component to be decreasing. If you see that drop, the multiple choice question is going to be choice C, a bronchopleural fistula. So it's something you want to alert the team to. Typically we get a CT. We don't always see it. We do see it here in this case where you see the bronchus running right out into the pleural space. It's a fairly common complication. Most of the time just managed conservatively with chest tube. You can have more dramatic breakdowns at the stump where they may have to go reoperate. Here's another complication after right upper lobectomy. Again, the middle lobe swings up. So this is actually the middle lobe after right upper lobectomy. You can see the vessels get kind of torqued because they have to, and the bronchus gets torqued because it's not in its native location. And this was an infarct, a vascular infarct, because of that angle that the middle lobe has to then take after the right upper lobe is gone. Something to look for. You can also have collapse of the right middle lobe as it gets replaced apically. Again, so it's the bronchus kind of doesn't like taking that turn, as neither do the vessels. So there's a case after left lower lobectomy where it looks like there is a filling defect within the left pulmonary artery and the left inferior pulmonary vein. I just want to talk about what that is and how to talk about that. I think calling it a pulmonary embolus is not really correct. Really refer that to in situ thrombus because it didn't come from the legs. Patients do get treated with anticoagulation. This was a follow-up that resolved. Segmentectomy is an option, and also for masses that are close to the bronchus. You can also remove a segment of like the right upper lobe bronchus, and they sew the bronchus intermedius back to the main stem. It just looks a little bit different when you're looking at the CT. Sometimes you'll just see sutures over the right upper lobe bronchus, for example, but you wouldn't see that here. So if it looks a little funny, or you don't see that over some bronchus, they could have done a sleeve lobectomy. Wedge resection, fairly common, kind of self-explanatory. It's also common nowadays for the surgeons to use video assistants or VATS. You can oftentimes see the after surgery, you can see where the ports were placed in the interosseous muscles. Sometimes there's a remaining defect there if those weren't sewn over correctly. Something to keep an eye out for. And moving on to lung transplant. Indications commonly see cystic fibrosis, bronchopulmonary dysplasia, COPD, and other types of pulmonary fibrosis are probably the more common reasons. You can get unilateral or bilateral transplant. This was unilateral on the right, and the patient has severe emphysema on the left. So if you see that discrepancy in a post-surgical patient, that's one reason to explain that. More commonly is a bilateral transplant where you'll have clamshell sternotomy, which is a bit of a telltale sign for patients who have undergone lung transplant. Really no other surgery uses that approach. The only other time that that's used is if someone needs access in the ED, for example, emergent cardiac access, they can do it, but it's typically not used otherwise. This is something that I saw them do not that long ago, but it's ex vivo lungs. I was kind of surprised when I saw this radiograph. These are lungs by themselves hooked up to both vascular and aeration. I think we have a video here. Basically lets the time for the lungs to repair before implantation. So that's kind of the aerated ex vivo lungs. Pretty wild. Moving on to some complications after lung transplant and the immediate time course. A lot of things that we're going to be seeing are kind of standard ICU X-ray stuff. So lines and tubes, pneumothoraces, fusions. Bronchial stenosis can be an early or a late complication. You can have size mismatch. Then moving on, you're going to have rejection of the transplant, both hyperacute and chronic, and infections. And the infections are going to be time dependent. So generally speaking, if you have an infection within the first couple of weeks, it's going to typically bacterial, hospital-acquired bacterial infections, not until later on into weeks and months where you can start getting fungal or viral infections, and post-transplant lymphoproliferative disorders are going to be more chronic or longer term chronic rejection, which manifests itself as obliterative bronchiolitis, and then recurrent disease is also possible. Sarcoid can recur. Cystic fibrosis does not recur because the calcium channels in the transplant lungs are fine. This is what they can either do an end-to-end anastomosis or a telescoping anastomosis. You can see that sometimes, so don't be too alarmed by that. But also looking for stenosis is just something to be aware of. Sometimes they'll pull a flap of fat to cover up the bronchus. So be aware of that technique. So again, most common mortality in the first 6 months are going to be bacterial infections. After that, it's more about graft dysfunction. There's a nice reference article if you need to pull this up on call and radiographics, just so you're aware that it's there. I'm not going to go into all the detail, but be aware that that reference article is there. Again, it helps to know the time course because as the lung, there's a lot of crossover in how these appear on CT. So it's nice to know the time course. Again, starting out initially with kind of mechanical pneumothorax, hemothorax kind of complications, moving on. Hyperacute rejections also possible during that early time point. Unfortunately, it just looks like edema. Then moving into some of the bacterial infections, then more chronic CMV and aspergillus as the months go on. We'll go into some cases. Invasive aspergillus is a favorite in the testing situation because it has immediate impacts in care. You'll see it in a lot of immunocompromised patients. What you'll see is a pneumonia that has a bunch of fuzzy stuff around it, and then it cavitates. So it's a cavitating pneumonia in an immunocompromised patient. You always want to think about invasive aspergillus. It's an emergency. They need antifungals as quickly as possible. In a testing situation, a lot of them are management questions because they want to make sure that you know that it's an immediately life-threatening disease that needs attention more than a Z-Pak. Send them home; they're going to be fine kind of situation. Also, in a testing situation, they can talk about fungal balls which is an aspergilloma, versus which is this cute little fungal ball in a pre-existing cavity. Doesn't really cause any problems. Kind of acute radiographic appearance, no big deal, versus someone who is going to die with an invasive aspergillus. The testing situation, you can imagine ABCD, they can have these it's the same fungus, aspergillus, so you can imagine the variations there. So it's a bit of a test favorite question. Again, aspergilloma, immunocompetent host, no big deal, acute finding. Needs immediate attention. Chronic rejection, it manifests itself as bronchial wall thickening. And if you think about diffuse bronchial wall thickening, it's going to cause air trapping. So what we'll want to do, it's one of the indications to perform expiratory imaging. So when you're protocoling, if the indication for the chest CT says concern for chronic rejection, you can either click our ILD protocol, which includes expiratory and prone imaging, or you can just do regular chest and write in, the comment section, do expiratory imaging. I just click the ILD one because I figure that will get screwed up less. But again, just know the importance of that expiratory phase to see the air trapping. Great. We'll move through a couple other thoracic surgeries, just so you're aware. This is one where there's a big hole to the skin on CT. Looks like this, basically filled with packing material and antibiotics. So packing material called a Clagett window or an LOS or flap. The distinction between those two is not as important for us, but I think LOS or flap is probably the more common one. It's open to the world, so just be aware of that. It's used to treat an empyema that won't heal. So the case looks like the rib cage was smashed in, but no trauma history. Somebody did this to them on purpose. It's old thoracoplasty, old prior treatment for TB, not done anymore, obviously, but it was before TB drugs. But every once in a while, we'll see one of these. See one of these around, supposed to suffocate the TB. If you see these little loops, you know that they've had a cabbage. That's basically markers for the bypass grafts. Those are designed to aid the interventional cardiologist. So if they want to interrogate the grafts with a catheter, instead of scraping along the aorta and flicking a bunch of clots to the brain, they put those little things there so they can just engage, the interventional cardiologist can engage the grafts because they're they're put in wherever they want to put them in. They're not put in anatomic locations, obviously. This is someone who had a CABG but doesn't have a median sternotomy, which is always a little strange. So just be aware that they can have different approaches instead of a median sternotomy. You see a valve repair. It's this mitral valve repair. It's good to know some of the different valves. It could come up in a testing situation where they say, which valve has this person had repair? That's fair game. This is something you never want to see on a postoperative chest. These little white lines here in the abdomen. This thing here, IVC filter, skin staples, bunch of clips, but this thing here should raise concern. As a Raytech, you do not want to see that in a postoperative patient. This is a similar lap pad, so you can see this here. You can see this here. These are things that you may get called about for a post-op check plain film or something you want to be able to recognize. Obviously a litigious area. Again, on aortic valves, this particular valve with this little three little crown looking thing, they could ask you in a testing situation, is this person anticoagulated? Would be kind of a nasty question, but it's out there. And the intent is that you know the difference between a full metal valve, which is this one, or tilting disc valve, versus this bioprosthetic crown looking one. The bioprosthetic crown looking one, this is a pig pericardium or something that they make that out of. That is, think about that as being more natural, so the patients don't have to be on anticoagulation. The full metal ones are less natural, so they have to be on anticoagulation. The downside is the metal ones, they last forever, but these don't last forever. These only last about 10 years, the bioprosthetic ones. So it used to be a big argument about how old a patient is, what's their life expectancy, whether to commit them to lifelong anticoagulation or commit them to a repeat procedure, a repeat sternotomy when the bioprosthetic one fails, or that was less ideal. But now that we can put valve-in-valve TAVRs, pretty much all we see now is the bioprosthetic valves. This is just a big hematoma after surgery. You can see compression of the right atrium and right ventricle. One thing we always want to keep an eye out for as we're, that's a TAVR valve. I'm sure you guys have seen those. Esophagectomy, you can often see dilated gastric pull-up. This one has an air fluid level in the right apex, which is concerning. So again, for esophagectomies, they take out the esophagus and then pull the stomach up and kind of create an esophagus out of the stomach. This patient had this complex fluid collection. You can see the gastric pull-up here. And then in the right apex, we saw this collection and a leak from the esophagus at the anastomosis into the right apex. A lot of, it's a difficult surgery, a lot of complications. This is a esophagectomy, but has a bunch of gas fluid levels in the anterior mediastinum. Not something that's done often, but sometimes they'll use colon. So they'll cut out a piece of colon and use it to bridge the esophagus to the stomach, which is pretty wild. It's called colonic imposition, esophagectomy with colonic in position. Some images of a jejunal interposition, so same idea, but just using some jejunum. These are just some images that I had from a friend, which I thought was pretty amazing. So it's measuring the size of jejunum they want and borrowing that to make a new esophagus. So CT is someone with a spit fistula, so there's a esophagus just goes right to the skin. You may have to interrogate this on fluoro, so just wanted you to be aware what that is. A couple test questions. Orthotopic heart transplant. Which portion of the native heart remains? Right atrial appendage, coronary sinus. This is posterior wall left atrium. So instead of sewing in all 4 pulmonary valves, they just cut around the pulmonary valves and leave the 4 of them. So on CT, you'll see kind of a double abnormal appearance of posterior wall left atrium. That's why. It's also just think about it as a easy way instead of sewing in these 4 veins, which would be 4 times the stenosis risk. A patient with bilateral pneumothoraces. They got 1 chest tube and no pneumothoraces, which is unusual. So they have to have a shared pleural space. It's also called a buffalo chest, usually a postoperative complication. This is a left ventricular assist device. I believe this is the HeartMate 2. Just to be aware of these. It basically sucks blood out of the left ventricle, has a little turbine thing in the metallic device, and then pumps it into the aorta. A lot of times we'll be looking for thrombus. There's a little bit of dead space in the bend relief here, so don't call that thrombus. That's not within the graft. That's just in a little dead space between this plastic thing and the Dacron graft. So be mindful of that. Sometimes the angle of the left ventricular conduit can get bent towards the septum, so it's sucking because blood's getting sucked out here. It can suck on the septum, so watch that angle if you're doing a CTA of that for complication. Again, that's that bend relief. That's not thrombus. It's normal appearance. Another thing to keep an eye on in all post-sternotomy patients is keep an eye on their sternal wires. So we'll be pulling tubes, and then around about a week out, be getting ready to go. This median sternotomy wire is not in line with the other ones. Used to be nicely in line. That is a big concern for dehiscence. This is here. So basically what happens is the sternal wires don't typically break in this time period. It's that they just get pulled through mushy bone. So you'll see one kind of migrating is the buzzword. So in a multiple choice setting, if you were asked what's the most common indication of sternal dehiscence, and choices were lucency, midline lucency, fracture of sternal wires, migration of sternal wires would be the answer. Choice C. This doesn't project very well, but you see this dense mass-like thing on CT. It's metallic density. So anything that's denser than bone, first you think contrast or something, but if this was a non-contrast, it would be equally as bright. This turned out to be a retained lat pad, and also another name for a retained lat pad that forms a mass is a Gossi-Pyboma. So you could see that as a choice in an exam. And if you didn't know that word, now you do. And that's from the genus cotton. Some young person who had tinglies in her arm when she did certain things. So vascular surgeon decided that it was because of thoracic outlet syndrome. So they resected her first rib. Then you have elevation of the left hemidiaphragm. You can have a lot of complications from thoracic outlet symptom repair. You can have phrenic nerve injury, pneumothorax, pleural effusion. If you think it's an effusion that is related to injury of the thoracic duct, or if you're chylothorax, which lab do you want to send? Make sure they send for. And there's no choice D, all of the above. But any triglycerides. All right, that's it. Again, my goal is just to record these quickly so you can watch them at your own speed. Please give me feedback. Let me know if this is a helpful format. Thanks again.